Okay. Okay. So, good evening, everyone. Thank you for being with us today, and welcome for joining us for this engaging discussion session. Our first session was introduced by Dr. Angie Abu Zaid, and it was about learning by concordance. And today we are going to present we have two presentations for Dr. and we are having Dr. Hadil Abdelkarim Mahmoud and Dr. Sadia Jabada. Javid, I'm sorry, will be with us. And first of all, we will start with Dr. Hadil Abdelkarim. And Dr. Hadil is an assistant lecturer of medical education, Faculty of Medicine, Suez Canal University. She is an ISME member as well. And the first presentation with Dr. Hadil is about the article Using Learning by Concordance to Develop Reasoning in Epistaxis Management. So, welcome, Dr. Hadil, and the floor is yours now. Thank you.
Thank you so much, Doctor. Good evening, everyone. It's such a pleasure to be attending the Journal Club and introducing. Thank you, Dr. Angie, Dr. Hind, and Dr. Asma, and all, and Prof. Wagdi for letting me do this presentation. I will present a very short article about learning by concordance. I will start sharing my screen now. 1 minute. Okay.
Recording in progress.
1 minute. Okay. I hope you see my presentation.
I don't know. For me, it's half your presentation. Can you set it in a presentation mode and then we can know? Yeah, it is now. We can see it now. Can you put it in a presentation mode?
Yes, 1 minute. Okay. Okay. Okay, so my article name is Using Learning by Concordance to Develop Reasoning and Epistaxis Management. It was authored by the following authors: Verard, Villoir, Kenya, and Thaguri and Fernandez, and he's very popular in his interest in the script concordance test and the learning by concordance, and Charles Bernard. Journal was Science Progress, and year of publication was 2024. Okay. The abstract is mainly about epistaxis management. Okay, as you know, the ENT epistaxis as a disease is very challenging to know its causes, and it's a very common to be introduced to the ENT residents, and they manage it in daily basis in the clinic. So it's a very complex and not an easy to diagnose and manage and know the causes behind it. So clinical reasoning in this part is very critical. The aim of this article was to evaluate how learning by concordance will affect the ENT residents training. Will it positively affect them to better think about the process of how they approach epistaxis management? It will enhance their clinical reasoning process or not. So the objectives was describing the LBC tool, assess its feasibility, report residents' feedback. Methods: there were 6 LBC clinical cases. I will explain in the session. Expert feedback and online participation. Results was high satisfaction about LBC, improved reasoning, knowledge gain, and in the conclusion was that the learning by concordance is very feasible and enhances reasoning for epistaxis cases. So what I'm talking about, I will explain now. Okay, as first, epistaxis is, as I say, the frequent cause of ENT consultation and emergency department visits. Management is complex, especially with underlying factors like hypertension or other diseases. As you know that many cases of epistaxis they diagnose this as idiopathic, and it has an underlying cause that must be treated, and they usually miss it because they don't approach the case in a good clinical reasoning way. So in any medical complaint or any disease we have, it's not one way. You have multiple ways. You can go to one doctor, he say one opinion, and the other doctor say, no, I will do an extra management or an extra investigation. The other doctor say it's better to take this drug. I see it's caused by another. So you don't have one opinion in medicine. You have multiple opinions. And generally, it's not one solution. Trainees must critically have a reasoning process and so through the management step they give to the patient. Okay. Can LBC learning by concordance be implemented for ENT residents? Does LBC improve clinical reasoning in epistaxis management or not? Okay, this is what the question. The methodology, it was qualitative descriptive. The sampling was 37 ENT residents doing the rhinology rotation in Paris. Duration was from October 2021 to Jan 2022. Data collection, LBC tool was online feedback. With online feedback, we use the learning by concordance. We re-implemented like clinical scenarios with the expert panel feedback. I will explain this, and the ethical approval was got by this number. Okay. First, I want to explain the methodology. The methodology was like this. You have 6 clinical scenarios. In each scenario, they have a different view of the abstract, different scenarios and clinical scenarios of the epistaxis complaint, where they have the feedback of the experts at the end in the panel. It was introduced an online platform where you first you have the scenario. 20-year-old female come to your clinic complaining of having nasal bleeding for acute or chronic for such a number of days. What chronic illnesses she have, and then you are in each part of your question. The question, the resident's questioning, what is your proposal diagnosis, or what will propose any probable hypothesis in the first, and then I give you new information, and then this new information change your thinking in the way we did such an investigation, CTE imaging, or you did an X-ray, or you have such a blood test that reveals that she has something in a blood disease or blood coagulation. So each step I give you new information to the resident that it changes. They give such that changes the thinking process to approach a better management or to change the way they suspected the etiology. At the end, the experts, the scenarios were judged by experts, several experts from different hospitals. They all give their opinions on these cases. So at the end, the residents were exposed to this panel opinions, and so how the reasoning process were in concordance with the experts. So they saw the experts were not on the same page they were in the same page in the diagnosis, but how they approach the management, the investigation, and the treatment were different between each one of them. So with minor difference, with minor variety, this enhances their clinical reasoning, and they reported this in the feedback they have given at the qualitative feedback. They were given a questionnaire at the qualitative feedback, and they were given open comments. So it was not a purely interviews. It was like a questionnaire given to them with comments they give about how it affected the reasoning process. The results that participation 25 of the 37 attended complete training. 80% appreciated the method. 92% reported improving reasoning. 96% gained knowledge in epistaxis. All found scenarios were a bit realistic. Okay, so discussion reason residents value the learning by concordance. Realism, expert insights, and complexity. Diversity of panel opinions sometimes confuse the learners, because when you have something you have in mind and you see this expert say a different management opinion, then you think about, so, and this expert say something, because you only depend on your seniors. The senior will say this, I will follow. So you have now different experts, your mind thinking different way, and you see what is better according to the evidence-based, and this give you better better understanding. 1 minute. Okay, so at the end, the conclusion that the learning by concordance is feasible and effective for ENT residents, recommended for complex clinical scenario, broader youth in ENT and other specialties advised.
Okay. Dr. Hadir, you were frozen for a few seconds.
What?
You were frozen for a few seconds, so we didn't finish the last bit.
Okay. Conclusion and recommendation. Now you hear me, right?
Yes. Yes.
The learning by concordance is feasible and effective for ENT residents. Recommended for complex clinical scenarios. It's more complex, recommended for the complex clinical scenarios, not like something that we directly manage, something that have different opinions, and you have, that is not easy to manage or diagnose or have the known etiology behind. Future research should be done more in the using of the learning concordance, because it's not like a case-based discussion or something direct. You have like this treatment and this management. No, you have different opinions. You can do one say that you can do a CT, an X-ray, and following investigation in blood. The other say, no, you can do another thing. So future research should measure objectives and improvement in such learning by concordance test. Now I will give like 5 minutes or 3 minutes for any question related to the article, and then I will start by critical appraising it according to the CASP checklist. If anyone have any question related to the article, please let me know. I will share again. Anyone have any question about learning by concordance or something related to the article? How the learning by concordance was done, was introduced.
Any questions about the methodology, how they implemented? I have one question. You said that they are just assessing the increase in or the change in clinical reasoning for the students and their perception, I think. But in the introduction, they have 3 research questions. So the second one is the feasibility of using it in ENT.
Yes, this was not addressed in the feasibility of using ENT. It was addressed in only the epistaxis in this research, and one disease in ENT. It is not the whole ENT, because the ENT is more surgical. Had more surgical entitled than the epistaxis. Epistaxis is only like one disease from a major disease. So it would have been better in this research if they introduced several diseases, not only epistaxis, so they can see if they address this question, it's feasible to be done in ENT, the feasibility of LBC learning by concordance in ENT. So because not all the diseases come to the clinic to the ENT is epistaxis. There are more diseases.
I think you will address this in your critical appraisal, because they are stating it as a research question, which is not feasible in terms of their study to say that if it's feasible for ENT residents. This is a very wide research question. How can you know from just epistaxis? So I think you will come to this through your critical.
Yes, I will come to this to the critical appraisal part. In the critical appraisal part, first I want to say in the critical appraisal we introduced several things. I'm going to share the presentation again, but I'm going to just say it in very simple way. We critically appraise how the researchers approach the aims of the research, if they address the research question, if the methodology was done and right, if the methodology data collection way was good or not, and then at the end we say if there is a limitation or not. You usually have some defects on the research. In this research, do you see that the author clearly state the research aims or not? You feel like if from the يعني quick presentation I give. You feel like they addressed the research aims or not? If anyone have any feedback about this? Yes, they addressed the research aims. Not totally sure about this. No, they didn't address the research aims.
You can use the chat if you don't want it to verbally contribute.
Yes.
So yes or no in the chat will be helpful.
Okay. Yes. Let's have some interaction. How are you? Okay. No interaction, so we didn't understand anything I said? Yes. Okay, perfect. Thank you so much, Dr. Marine. Thank you so much. Okay, it's totally right. It addressed part of the part of the research aims. I feel like it was the research aims were a bit generalized. They were not specific because they tried to imply to the ENT specialty in general, and it was specific to only the taxes. But yes, as a part, it addressed the research aim. Another thing I want to ask about in quick was the qualitative approach appropriate to this research or not?
I think no, Dr. Kadir, because I didn't find, I was going to ask about this because it didn't, you didn't show in the presentation, and actually this will be in the paper. What are the results for the qualitative study here? Because you just give a person with the participant opinion regarding the gain, the clinical reasoning, or they are satisfied about this, but actually no apparent results for the qualitative. So I don't think it was apparent enough in the research.
Yes, perfect, Dr. Hind. Wallah, they should have been gone deeper in more interviews. If they are going to use qualitative, they should have done more interviews, more focus groups, and I felt like they should have expanded the area. Got feedback from all the people who are participants. I felt like they could have done a quantitative part of it. Also, analysis, they could have done more than the qualitative approach, because this research learning by concordance, you can approach it qualitatively and quantitatively. And they could have examined also the ENT residents in their performance, have a pre and post test. This could have been done. It would have been made the research more more robust in my opinion. So I totally agree with you in this part. Anyone have another opinion in this area? You feel like
question
yes.
next is Dr. Mona Abdelnour. She is asking also, is qualitative research enough?
No, in this, it's qualitative research is in this article alone, I feel, in my opinion, and someone can have a better opinion than me, I feel no, it is not enough. And if you are going to do qualitative research alone, you should have been gone deeper. You should have combined it with interview focus groups. So I felt like it should have not only.
Adil, I'm confused about something.
Okay.
In the results, they have a questionnaire that is have been marked as moderate, slightly, very extremely, and they are giving quantitative data in the results. So how this research is just qualitative one?
Yeah.
Because it was like they give a percentage, but it was open-ended question. It was like not yes and no, not a questionnaire, if I understood from the research, but from my understanding from the research. It was not a pure questionnaire with the results given 15, it was purely open-ended.
Yes, but still he have to say that's qualitative, makes it qualitative, quantitative. It's basically a quantitative, not a qualitative, I think, in my opinion. I doubt at this point
his results is more quantitative than qualitative one.
Yes, I think so. And I
it's part of qualitative because they have open-ended question, the quantitative was like they have a board quantitative, but like the feedback from them, it was like a cross-sectional at the end. يعني they have their perception at the end. So
You
maybe
mean
yes.
that it should be a mixed method?
يعني it should have been a mixed method. I feel like it should have included quasi-experimental. Yes, you are totally right. I didn't explain this in a good way. It was quantitative and qualitative in a part, but the quantitative was not the quantitative I was planning. يعني I was hoping they would do like a quasi-experimental. They have a pre-test or post-test or more or more qualitative way of doing interviews or focus group. They have like perception, yes, part quantitative. This part I was not addressing right, and part of open-ended question at the end of the questionnaire. They introduced, yes, and it was not a totally interviews. يعني it was not a face-to-face interview. They gave a questionnaire with open-ended question, and part of the question was like rating. So yes, it was mixed. It was quantitative and qualitative partly, but not in depth. Not quantitative, quasi-experimental, and not qualitative by interviews and focus groups.
Dr. Hajid.
I think in the study they mentioned that they are having they had a qualitative design. They mentioned this in the methodology. However, in the results, it's not qualitative data at all. So I think this is a major a major point that the reviewer should identify.
Yes, they said the design, it was a qualitative design.
It is not
Yes,
a qualitative.
they did it directly, so I felt like the questionnaire was not, they considered it as not a quantitative part. The perception is very weak to take an LBC alone, because if you are going to study LBC in a research, you should do more, actually. Not only a questionnaire or only using an open-ended question, you should do more. If you are going to use qualitative, you should have clearly interviews with clearly quotes of what has been said with the experts and the residents, and have focus group. So no, it's not a qualitative design. This is a major flaw. Saying in the study design, qualitative design, and you have administrated a questionnaire. Yes, totally right, Doctor. Yes.
Yeah.
Okay, so another question, what about the recruitment strategy? Do you feel like they invited all the eligible NET residents? You feel like there is any selection bias?
I saw they started by 37 and they mentioned only 25. 25.
Yes.
This is convenient for them, or مثلا why they are missing this a lot of number of participants?
Dropout rate. They didn't have all the sample size they were targeting, and I felt like it could have been generalized if they have residents from different from different hospitals. And they didn't mention if they said in the rhinology rotation, so I felt like they targeted only one hospital. And doing it online, you follow, not all answers the question. You don't have proctoring or monitoring the residents while they are doing the sessions. So not all participated. So I felt like they needed more. They needed more sample size in this questionnaire. It was not.
You mean the confounding factors a lot?
Yes.
There is confounding bias in during collection of data.
Yes, I feel like this.
I think again, Dr. Hadid, we can't judge this point specifically, because I think if they from the beginning start to design their manuscript or research work to be a qualitative study, so actually they are go for purposeful sample, and sample size, I think in such way would be much less maybe than 25. But actually you are commenting as if it is a quantitative study. So you are asking about more and the selection criteria, was it randomized or not, and with more sample size. And it can be judged again because as we mentioned, you have a major focus.
I'm so sorry for interrupting you. I'm starting my career and I'm reading the paper. I know that Dr. Angie actually was mentoring me and told me she's the one that first introduced learning by concordance and clinical reasoning to me. I have basic qualitative design and they have questionnaire at the end, so I had like an error. So it's okay. You consider it
I think it's very good, by the way, presenting something like this because it helps you to detect what is what the flows. It's very good, by the way, to have something like this for discussion and know when to critique or how to critique something like this.
And I would like
Thank
to
you,
ask her because she pointed to something about the confounders. Actually, the residence experts levels were
Yes.
different. The baseline knowledge was not assessed.
Yeah.
The motivation and engagement levels were also not assessed in this. Residents who value the online tools or reflection may be morely like to participate and report positive experiences than the others.
Okay.
So I don't know what influenced their experience and what is they found best or bad about it. So I felt like they needed to do interviews and different focus group. This is what I think about it, يعني. But totally right. يعني, I have an error in the qualitative part. Thank you, so Dr. Angie.
But I think there is a difference if they are just doing the perception of someone who has the training or has the LPC. That doesn't mean that you have to test the pre and post test because they didn't talk about the improvement in knowledge. So is it a perception study?
Yes, I'm agree with you, Angie. Yes,
or they
يعني
are
there is
assessing
there is no assessment of knowledge to test pre or post. Just they need to know about their satisfaction about that trial.
perception.
But I'm agree with Hadil that there is
Go back again, Dr. Asma, to the research questions. It's not a perception only because they have 3 questions. Let me go up to the intro.
Yes, because data, it's mainly it was perception because the data was collected by online questionnaires that was embedded in the LBC platform. They focused on the subjective experiences, and they didn't have. When you have an interview and focus group, you see how they think, you see their body language, and you usually have a very good insight on how this learning by concordance tools influences them. So I felt like it's totally perception. I didn't feel something.
But if you go back to the questions again, so the first one is to describe the development of the LBC tool in ENT on epistaxis, which they already mentioned. The second one, which they didn't, is to assess the feasibility of using this in ENT
approach,
which is
yes.
difficult to assess. However, the third one is to report the result of their evaluation. So it's more about perception, yani describing the development and the evaluation of their experience. So I don't think they need to have a pre and post test in this study. I know, Hadil, you are speaking about from experience because reviewers were very harsh on you when you for pre and post, but for them, I think this is just perception. For me, the second one haven't been fulfilled, which is the feasibility, because they can't do this in this small sample size.
Yes.
And I think the qualitative part is a typo. I think it have been written incorrectly and it was quantitative because the whole study is following quantitative. So maybe it was a typo at the start. We have Dr. Nizar wanted to contribute.
Thanks for this perfect presentation. I think from clinical point, the author can add some question to measure the knowledge, as which knowledge add to you, what is the most opinion of expert add to you. He can add some question to measure the add knowledge instead of pre and post test.
Do you mean that they can add open-ended question at the end of the questionnaire to explore the change in knowledge?
Or a specific question. يعني there is a hot point in diagnosis of any disease as epistaxis. He can from his experience at a specific point, what is added knowledge in this point, this area. Can also ask about which add from opinion of experience. This question maybe increase measurement of knowledge added by this test.
Yeah, Dr. Ridwan, I'm talking from experience. We had the first study about LPC, but we didn't have a pre-test, and we only have a post-test after and the perception after the study. And one of the, not one, more than one from the reviewers comments that you can't assess that there is increase in the knowledge without having the baseline. So in the further studies like Hadil's study, we were keen to have the pre-test, so we know what is their level, and then we give them the session. And now, if there is any change in their knowledge, we can contribute it to the training. So that's why Hadil is emphasizing that if they are assessing knowledge change, they have to have the baseline or the pre-test results in order to make sure that they know the baseline of all the participants, because you might have a variety in the experience of the residents. Some are good students or some are lazy students. So that's why she's emphasizing on the pre and post. But for this study, I don't think they are actually assessing the knowledge. They are just assessing describing the design or the process and assessing the perception.
Yes, but I felt like this was how confused. I felt like it's not it's not purely, it's quantitative primarily, yes, quantitative, but it's not purely quantitative because the data collected were structured and human satisfaction rating was taken. The author did gather some limited free text feedback from the participants. I felt like the results were, yes, there has a percentage of their satisfaction, but at the end they said more about the comment they get at the end from the residents at the end of the questionnaire. I think they have, I didn't have the access to the questionnaire actually, but from the results, I feel like they have open text at the end. So they give their feedback. So from this point, they consider it qualitative, but this is a typo, as you said, Dr. Ng. So, but there is no formal qualitative analysis. So the qualitative component remains superficial. No, it is not. I think, yes, it was a typo. But they depended on mainly the comments, so they say it was qualitative.
I want to add something. I think Dr. Nizar means that he need questions to be included to test this resident's knowledge, clinical knowledge, and these questions already included في learning by concordance. The aim of this test is aiming on their reasoning style and how to approach the case of epistaxis. So the researcher can test their knowledge and their approach through the results they are following the test. But I'm agreeing with Hadil that no controlling, no proctoring. We didn't see if they have any kind of assistance to solve the exam or this test. So maybe there is bias or over exaggeration of their marks of their scoring regarding the concordance. Also, I'm agreeing with Dr. Ng regarding her point about that there is a point of research. They are asking that if this is visible to be used for all NET cases, using one case like epistaxis as a sample for all NET is not good. So the study containing many limitations, like what mentioned by Dr. Hadil and Dr. Ng. So I'm in agreement in this part. Thank you so much.
I want to add something in this point. Dr. Ng and my supervisors may correct me. In the paper, I want to share something. 1 minute. Yes, in this part, this is an example of the learning by concordance, the clinical vignette. If you are thinking or administrating an anti-hypertensive medication, and you subsequently learn that the patient is already treated for hypertension and that he took his anti-hypertensive medication 1 hour ago, what's the impact of this new piece of information in your intention and management? Will it strongly negative, it will affect your management process or not? So if I'm a resident with a good expert, يعني with a good clinical training in the epistaxis, good basic knowledge in the epistaxis, I will agree with the expert's opinion, the majority who said two panelists, and I will interact more and feel like this learning by concordance tool affected me positively. If I have a low baseline and I don't know more about epistaxis, maybe I will not feel like this was very beneficial to me, and this doesn't increase my so يعني what I want to say that my perception, even if I'm reporting the evaluation and feasibility of learning by concordance, may be affected, and it varied according to my knowledge. So if you have someone with a good knowledge, he has different يعني a good baseline knowledge, he have a totally different perception with someone who have not a good يعني a low baseline knowledge or have nothing to know about epistaxis. So I
Yeah.
felt like having a baseline knowledge was very important. يعني you can correct me in this part.
I agree with you, Dr. Hadir, for this because يعني, as you mentioned, we have different perceptions here according to the knowledge of each other. This is why in such case, a qualitative study will be appropriate to take their opinion regarding the importance of developing their clinical reasoning in such specialty. Even if I'm building it on epistaxis or any other variety accordingly, using different cases and see does this raise something in them or not. Yeah.
Yes.
Dr.
Yes.
Can we proceed to the next section? If reading next section, are you going to comment on the conclusion, for example?
Yes, I want to comment on the conclusion. For the conclusion part, I wanted to ask about if you feel like in the conclusion, they address the conclusion in a good way and they have the final reflection, or is there any limitation existing or not? يعني where in the results you feel like the findings were I want before going to the conclusion.
Hadil, can you share the conclusion?
Yes, one
The article ready on your laptop.
minute. I have an error. Okay. Okay. Can I share the conclusion from the paper? One instead of this.
Yeah, it will be better, yeah, if we can share it from the
because I part of me stop share. Okay, documents. Okay. The results of this experiment, this first experiment using LBC and NET demonstrate a great interest among residents and suggest applicability in other fields. I don't know how they get this, yani, including a continued professional development. The conclusion of our study is that the concordance learner tools can be developed and used efficiently for training future ENETs. What do you think about the conclusion? If anyone had an opinion about it. I feel like it's more, in my opinion, someone can correct me, I feel like it's more generalized, it's a bit generalized and should be more specific.
And not reflecting the results or their methodology.
Yes.
Take, as mentioned by Dr. Enji, especially the point number one, first statement, when they are saying can applicable, the residency, it is applicable for all other fields. And there are very few sample size from one place. In one case, epistaxis, yani, even we can't say that they can apply in all cases of NT, yani, not all fields. So
Yes. Anyone have another opinion? The same. It was vague. It was not clearly stating the results. I felt like they didn't, in the limitation, they should have report يعني in the limitation part I want to go through the main limitation of this work, like in the fact essentially a descriptive study based on self-reported data about the development. You didn't say it's not qualitative يعني the data collected was a non-validated questionnaire reflects the subjective perception of the students about this innovative format. Further work will be necessary to evaluate the benefits for students in the term of knowledge and reasoning skills. And then they should have mentioned in other areas of ENT, and they should have mentioned that more methodology, further methodology, and more robust methodology should be done, not only a questionnaire. So limitation, they have a lot of limitation they should have addressed in this area. This is for the conclusion part. Final question in the CASB I wanted to address it actually the part asking about if you feel that the limitation was adequately addressed or not. يعني I want to have your opinion also, not only my opinion in this. Okay, 1 minute. So usually we addressed all. Another question in the CASP, how valuable is this research, you think? Yes, no, you cannot tell. This is what I wanted to ask. If I can have your opinions. Is this a valuable research, or you feel like it was not valuable? Or you cannot tell, you cannot decide?
I think it's valuable as a preliminary evidence.
What? I cannot hear you, Dr. Manish.
As a preliminary evidence, this is a pilot study that could show to some extent that valuable methodology in advancing clinical reasoning, but because even regarding the qualitative issues that you discussed before, I think they have asked two more questions, like students were asked to identify two strengths and two areas for improvement, and this is related to qualitative nature. They have to mention something, and this is not something quantitative. And they described in the results as the elements that could be improved. The diversity of the panelist opinion was something confusing. This is something to be improved. The lack of consensus for students to make up their mind. So this is one of the issues that were to be improved. And the brevity of the clinical vignette could occasionally simplify the clinical situation. This is another issue to improve. And the feasibility of the Likert scale. Overall, I think this paper could be valuable as a preliminary evidence for the methodology or the use of LPC for raising the clinical reasoning for residents. But I agree with you that it has to be supplemented with more and more research with larger sample size and more robust methodology to convince to be used.
Yes, perfect, Doctor. Perfect opinion. Yes, I totally agree with you. A lot of research should be done more in this. It will be valuable that it gives you like an idea of what you can do more in this area. But I felt like it doesn't address the methodology doesn't address the research objectives in a good way. And actually, there is another question in the credit because before I want to end this session, this part of my session, so I will not be taking long time. I read the research. In my opinion, the research, I will tell you my opinion, but I want your opinion. You felt like from my presentation, have the relationship between the researcher and the participants, the residents, have been adequately considered or not? And it's important to know if they have a relation. This question is important, this research or not, to critically appraise.
Sorry, Hadira, I can't understand the question. What do you mean by the
research يعني relationship between the researcher who's doing the research and the residents or the participants or the experts have been addressed or not?
Because
The residents he was training or had relationship to?
You mean as a conflict of interest?
Yes.
yes,
Oh, okay. No, I
Because
don't
And
think
I have another opinion, Dr. Angie, for this question. I think if they are planning for the qualitative study, they pose this question to know if the researcher intervene with his opinion to their responses or not. But I think this is the aim of the question, but actually, again, no apparent result for the qualitative study to judge such a question. And this is my opinion regarding this. Yeah.
Yes, because all of us agree that this is not a qualitative, so it is a quantitative one. So nothing from the qualitative will apply here. I actually am not sure what the question is addressing here, if it's a conflict of interest or a researcher bias.
Yes, at the end, I like to end my session, so not I will not take a long time. If no one has any question or anything about the research that we introduced now, it's very great that we think because I have a different thought and a limitation because I'm starting my career. And thank you, Dr. Angie, for letting me do this critical appraisal with this research. I feel like the study showed that the development clinical reasoning is not just about teaching the answer, it's about teaching how to think in complexity and uncertainty. This is how the valuable of learning by concordance tool in any research teaches me, that when you teach someone, you have to teach him how to think in uncertainty, not to teach him the answers only. That tools like learning by concordance it's very important in the clinical field, and you may have the perfect authors, but you have major defects in the research. I felt like not only the qualitative part was not the essential part. It should have more. It was not addressed, and it should have more interviews and focus group. But more importantly, it should have a baseline knowledge because it will make the research more better, and should be generalized more, and more researches should be done in this area. Thank you for letting me participate in this session, and looking forward to more interaction and sessions with you. And if you have any question, let me know. Otherwise, thank you so much.
Thank you very much, Dr. Hadid, for this impressive discussion, for your presentation. Thank you very much. So now we are going to have our second speaker in our session, Dr. Sadia Japid. Dr. Sadia is an assistant professor of physiology at Rick Medical College in Pakistan. The talk of Dr. Sadia today, with the article Dr. Sadia is going to discuss, is about using the script concordance test to evaluate the clinical reasoning skills in psychiatry. Welcome, Dr. Sadia. The floor is yours. You can go. Thank you.
Am I audible?
Yeah, we can hear you clearly, Dr. Sadia.
Yeah.
Can you go on and share your screen, please?
Thank you for giving me the opportunity. I am going to share screen. Just a minute.
We can see your screen yet, Dr. Sadia. Do you want to unshare and share again? Dr. Sadia, can you hear me?
Dr. Angie, if there is a problem, I can share from me here.
I think we lost Dr. Sadia.
Yes, yeah.
Apologies everyone for these technical difficulties, but hopefully we'll sort it in a minute. Dr. Sadia, can you hear me?
I think هي خرجت ورجعت وهترجع تاني وخرجت تاني دكتورة أنجي. I think she have an internet problem. اسمعتني تاني.
I can see her in the participant.
ما هي starting there. Yes, awesome.
Now my screen visible.
Yeah, we can see your slide, but can you make it in a presentation mode?
Okay,
Yeah.
now it's in.
Yeah, we can see the slides and we can hear you.
Yes. So the topic of my presentation today is, just a minute. Okay. Using the script concordance test to evaluate clinical reasoning in psychiatry. The authors are Skazor, Semi Richa, Marwan, Zogby, Wissam Al Hage, etc. The journal is Academic Psychiatry and it was published in the year 2016. Now, first of all, the abstract, the introduction, clinical skills are crucial in psychiatric training, but these clinical reasoning skills are poorly evaluated by the existing tools. So, actually, in clinical reasoning skills, the physicians use scripts. Scripts are organized knowledge networks which are already in the mind of a clinician, which basically they use this information to navigate the clinical scenarios. Like whenever a patient comes with any problem, the clinicians use these scripts in mind, the information they have acquired throughout their life from the first clinical scenario till the whatever experience they're undergoing through. So they use all this information to treat a patient and manage a patient. So the objectives of this study was that the script concordance test was created specifically to measure the clinical reasoning under uncertainty and evaluate the effectiveness of this script concordance test for the 7th year medical interns during their psychiatric training. So these were the two objectives. I will explain all these things further on. The methods used were performance was measured at both the start and the end of their psychiatry training. And it is used to determine whether this test can reliably capture the improvements in the clinical reasoning skills of the interns. So a panel of 10 psychiatrists and 47 interns participated to this study. The 10 psychiatrists panel was used as a reference panel. This reference panel performed significantly better than the students. And the interns also improved significantly their scores between the start and the end of their psychiatry rotation. So the students improved significantly their scores after taking this test. So after taking the training in psychiatry, actually. So the conclusion that this was the first study which was conducted in Lebanon using the Script Concordance test in psychiatry. And this study shows the reliability of the concordance procedure and its utility in the field of psychiatry for evaluating the students in their clinical reasoning um, skills, and it can provide a valid alternative to classical evaluation methods. So first of all, I will basically carry on the discussion along with you. So first of all, I want to ask that did this study addresses a clearly focused issue after you have gone through the abstract? You can type in or comment. Am I audible?
Yeah, we can hear you. Yeah, when we only
I
have some
I've asked this
there's
question.
in answers in the chat. So some saying yes, and Dr. Rania Hamid said to some extent.
Okay.
Any other
So
thoughts?
now I will move forward with the details of the study. Yes, now the introduction. Actually, the traditional medical training tools like the supervised clinical examinations or multiple choice questions or extended matching questions, they struggle to standardize and generalize the uh, assessment of clinical reasoning. Like clinical reasoning skills, as you all know, that these are the judgment and the insight skills. And the clinical reasoning skills actually they test the competence of a clinical physician. So traditional medical training tools are unable to assess them. So in uncertain scenarios, what happens that we need some good assessment tools. Now the script concordance test that was developed by Charlin et al. And it is a tool which targets the clinical reasoning in uncertain clinical situations, like when it is difficult to make a diagnosis, or when a patient comes with multiple problems and he's on multiple drugs, then these are the situations which basically test the competence of a clinician. So such situations are tested by the Script Concordance test. So in uncertain scenarios, so clinicians activate the already background knowledge or scripts in their mind to generate and test the diagnosis or treatment options. So each new piece of clinical information either reinforces or rules out the diagnosis. So the Script Concordance test, as you all know, that it consists of different vignettes, a clinical scenario followed by several items. So vignette is a brief clinical case which is used to test the diagnosis, um, hypothesis, treatment, or management options. And then the 5 items are given below. So each following item explores a possible hypothesis for the script. So this Script Concordance test was successfully studied in several medical fields like emergency medicine, dermatology, and radiation oncology. So the authors, this test has not been studied so far in psychiatry. So in 2016, the authors decided to test this Script Concordance test for psychiatry. So they have 2 objectives mainly. The primary objective of this study was to develop a strip concordance test in the field of psychiatry and to introduce a new model of evaluation for mental health educators. And the secondary objective of the study was to use this test for the evaluation of interns during the 7th year of medical studies at the beginning and at the end of their 1 month training in psychiatry. So the method that basically it was a case control study. Like one group was the student group and the other group was the experienced psychiatrist group. So these two groups were compared. The student group consisted of 47 interns doing their psychiatry training, and the experienced psychiatrist group were recruited from two universities, psychiatry departments, St. Joseph University and Lebanese University in Lebanon. So the expert panel answered the strip concordance test after all the concepts were explained to them, and the duration of this study was 1 month. The students or interns which were selected, basically what happens in Lebanon, that every month 4 new interns have their psychiatric rotation at Psychiatric Hospital of the Cross. So all students doing their internship during a 12-month period were recruited, and all students had previous knowledge of psychiatry, previously pursued. They have psychiatry courses. They have taken 40 hours of lectures and clinical case discussions during the last 2 to 4 years. And then they were specializing in this field. So now I want to ask that were the cases recruited in an acceptable way? Sorry. And were the controls selected in an acceptable way? You can answer in chat. Okay. So you are saying yes, so I'm moving forward. Now, the methods in detail. The 48 interns were evaluated at the first and last days of their training at a 1 month interval. One student was excluded for having a previous clinical training in psychiatry. Basically, he had a full clinical training in psychiatry, so he was excluded. So authors analyzed the data of 47 students, and all interns were informed about the study objectives, principles of SCT, and formal consent was taken. Now, psychiatry internship is a training of 1 month where interns are confronted to different clinical cases of psychiatry, except weekly staff meetings and article presentations. No formal lectures are given during this internship. And the ethical approval was taken. Approval of the Committee of Pedagogy of Faculty of Medicine was taken for this study. Now we will continue the methods. The SCT consists of short vignettes describing the clinical situations in psychiatry. These clinical situations reflect the real cases or the uncertain diagnosis or different management possibilities. 5 items follow each vignette. And as you know that the items which are below the vignette, these show either a possible diagnosis, a treatment option, whose impact on the initial option is measured with a 5-point Likert scale. So in the Likert scale, we have 5 options from -2 least probable to +2 most probable. The Likert scale measures The Likert scale measures if the new information makes the proposed diagnosis more or less probable. Now, the example of vignette I will show. So this type of clinical vignette was made. I'm showing only one example. 20 such vignettes were made. Like you can read the vignette that it's a vignette from the psychiatry. First of all, there is a clinical diagnosis which is shown. And then these are 5 items which are added below. And then the options from -2 to +2 are asked. Okay. Now, to define the correct answers, the test was taken by a reference panel of senior experienced psychiatrists between 5 to 18 years of experience. For any question, the most frequently chosen answer was given a credit of 1 point, while the never chosen answer was given a credit of 0 point. Other answers were given partial credit. The test was designed to evaluate interns during 7th year of medical studies. All the clinical situations which were chosen for SCT covered the psychiatric disorders like anxiety disorders, bipolar disorders, depression, mania, childhood and adolescent disorders, substance abuse. The test was developed by a psychiatrist, this SCT, and reviewed by a senior psychiatrist and 2 senior residents to ensure the credibility of the test. And the test included 100 questions. And this test basically explored 2 axes of competence. Diagnostic reasoning, mainly 75%, it included 15 vignettes about the diagnosis and 5 vignettes about the therapeutic reasoning. Each student and expert was given 90 minutes to take the test. The test was taken in a classroom without access to any reference. The language of the test was English. The reference panel scores was established using the following rules. Most frequent answer was given a credit of 1 point, and never chosen answer was given a credit of 0 point. Other answers were given partial credit. The student scores were determined using the reference panel scores. For each question, an item analysis was performed regarding its ability to discriminate between the students and its impact on the overall reliability. Thus, each question can be categorized as good with a correlation coefficient of greater than 0.2, fair with between 0.1 and 0.2 correlation coefficient, and bad with a correlation coefficient of less than 0.1. Now the statistics, all data was entered using Microsoft Excel. The internal coherence test coefficient was evaluated with the Cronbach's alpha test, and the coefficient, the values of Cronbach's alpha test, as you all know, between 0 and 1 indicates greater homogeneity between the articles as values approach 1, and good reliability is indicated when the coefficient is above 0.8. So I want to ask, did the authors use an appropriate method to answer their questions? Okay. And next question, was the exposure accurately measured to minimize the bias in the study? Okay. Now, now the stats scores were determined within 3 groups: reference psychiatrists, interns before training, and interns after training. Quantitative values were described by the mean, standard deviation, and range. Confidence intervals of greater than 95% were calculated. Comparison between the students before and after training, and reference group scores were undertaken using the Mann-Whitney test, and p-values of less than 0.05 were considered significant. So I want to ask, aside from the experimental intervention, were the groups treated equally? You can answer in the chat. Yes, it will come. I will discuss this detail in the investigation. Yes, the same vignette test was used before the training and after the training. Now, the next question, have the authors taken account of the potential confounding factors in the design or in their analysis? Yes, they have said in the discussion, it will come forward that this was a bias in their study, but as it was a pilot study, so they use the same test in the before and after training. So the results now. The test, as you all know, composed of 100 questions. The reference panel was of 10 psychiatrists. Now, these experts gave the answers of extreme values from minus to +2 in 27% of questions. And 47 students participated in the study. Now, the reference group had a mean score 79.42, significantly higher than the mean score of students 58.47 before their training. I'm showing the results in the table. You can have a look. Now, these are the scores of reference panel on the right side and students pre-rotation on the left side. And the p-value was highly significant. Okay. Now, after training, students improved 11% of their scores on the script concordance test. The score increased from 58 to 65.04, significantly higher than the scores before training. The mean difference between the pre and post training scores was 6.57 plus minus 4.78. Cronbach's alpha coefficient of this script concordance test was 0.79. This script concordance test contained 19 bad items, 37 fair items, and 44 good items. After removing 19 bad items, the Cronbach's alpha coefficient increased to 0.87, which was a very good value, and the number of bad items decreased to 3. Now, these are the comparison pre-rotation and students post-rotation. They have written that they basically they converted the Likert scale to model transformation, and in SPSS basically they have driven all the results. Now I want to ask, do you believe the results? Okay. And the next question,
Dr.
can
Dr. Shadi, if you allow me, can we hear from Dr. Rania what is her doubts?
yes, yes. I will also take the questions at the end, but of course, Dr. Rania wants to add something. I am listening.
Okay, the test has 5 vignettes for diagnosis, I think, and the rest of the vignettes testing the therapy. I think
Yes.
this is inconsistent when considering the consistency of the test and also the memorization bias. When the vignettes are
Yes.
the same, pre and post, I think there will be memorization bias in the results.
Yes, they have discussed it in the in upcoming discussion. I will tell you more in detail that they have said themselves that basically they made the script concordance test according to the type of training they were given to their interns. Like they have given 75% more focus on diagnostic skills, and 5% they have the focus was on therapeutic skills. So they designed the vignette accordingly, 75% on diagnostic reasoning and 5% on the therapeutic procedures.
Yeah,
So this was the explanation made by them. And I also think that in psychiatry, diagnosis is more important, as you all know.
Yeah, Dr. Sadia, if I may comment, even while we discussed in the first session that the question, it depends on the table of specifications that we had. So the idea that they have mentioned that it resembles the training give the question more validity. So it doesn't mean because we have 3 domains in clinical reasoning that the exam has to have an equal amount of items that are assessing each domain. It should follow what you have taught. So it should follow your table of specification, same as Dr. Sadia have added now.
Yes.
Regarding the pre and post test, we actually had this problem with one of our study, and we did the same. We used the same test in pre and post, because there is another bias that you might fall in when you use different tests, that you have to make it equivalent in the term of difficulty and in the term of other reliability items. So it was safer to have the same tissue, sorry, the same test. Yeah, this is what I'm saying. Equivalent test isn't an easy thing to develop. So we actually use the pre and post, but we mentioned in the limitation that it might have a bias, a recognition bias.
Yes, they have. They've been said. I will discuss further in discussion that they said that this was a bias, that the same strip concordance test was used in pre and post training, but actually this was a pilot study, and they just wanted to see that whether the strip concordance test is feasible or not. So they applied the same test, and then they saw that the students improved after rotation. Like the questions they were unable to answer in pre-training, they were able to answer that after 1 month. So they have said that this is the bias. This is the limitation of the study. Okay.
Yes, please proceed.
Okay, now I want to ask, can the results be applied to the local population of this study? What do you think? Yes. Okay, and do the results of this study fit with other available evidence? Okay, now I'm going on to the discussion. This was the a pilot study. It was the first study in Lebanon in they've done in psychiatry, and they basically have used other fields reference. That strip concordance test was employed, and so they want to try it in psychiatry. The cases which were used in this study were taken from real clinical situations and adapted to the level of knowledge of students. Like 20 clinical vignettes were made, 15 were diagnostic, and 5 were therapeutic. And they were mirroring the interns' 75% diagnostic versus 25% therapeutic coursework were used for this study. So the answer of doctor has been answered here. Now, the second point, expert panel and reliability. The reference panel used were 10 psychiatrists with the hospital and teaching experience. And the test reliability was solid because the Cronbach's alpha coefficient was 0.87. And when the Cronbach's alpha coefficient is greater, you know that this study can be used in high stakes evaluation, like it can be used in assessment programs to give a degree for graduation purposes. So this is a very good assessment tool according to the authors. And the experts, of course, they have the higher scores. They outscore the students, confirming the skip concordance test ability to distinguish the levels of clinical expertise. Like this is the advantage of the skip concordance test, that it can differentiate between the level of expertise among the clinicians, between the experts, between the juniors and the senior residents. The third is detecting learning gains, like interns took the strep concordance test before and after a 1 month psychiatry rotation. So post-rotation scores rose significantly, and the strep concordance test successfully captured the improvements in clinical reasoning skills. Now, the strengths of this approach is that it allows exploring several clinical situations over a short duration. Like you know that if we in supervised clinical examinations, when you are taking short cases or long cases, you can only three short cases, or in long cases you can only employ one or two, but it allows exploring even 20 clinical vignettes, on their numbers can be increased. So it is an objective test. In supervised clinical examinations, there is a bias in different patient, like patient are different, and simulations are different, and the examiners are all, of course, different. So that becomes subjective, but it is an objective test, and it is a reliable test, and it can be repeated for an unlimited number of times. Like you can make many script concordance tests, and you can evaluate multiple times. And the situations used in it are, they mimic the real clinical cases, and they help in evaluating the clinical competence skills which are gained by the students during their training. And it complements other assessment methods like OSCE's case studies and supervised clinical examinations. It can be used with them. It cannot totally replace them. So the identified limitations in the study was that it was a single site study. It was run only in one hospital, in the Psychiatry Hospital of Cross, and it cannot be generalized to all types of rotations. Like according to this study, and the small student and expert samples were taken. The authors have themselves said that they should have increased the expert samples to 15 psychiatrists, but they said that they have only 60 psychiatrists in Lebanon, so they can't increase the expert numbers. And they have mentioned that the potential bias is that the same test was used pre and post, so students already knew they would retake it. And then one limitation is also that only 27% of items had extreme model answers. If this proportion was to increase to 50%, then authors would be able to avoid bias in the study. And again, they have said that there is no senior psychiatrist comparison group, and no test retest control, like no different test and retest was employed. So these were all the limitations which were in this study. So they have recommended different recommendations that this study should be expanded to multiple centers, and diversified rotations like outpatient and community psychiatry should also be included. This was actually only an inpatient hospital ward psychiatry. Increase the expert panel and refine the item keying, like using more extreme anchors, the number should be increased to 50%. And they have recommended that this strip concordance test should be used along with other assessment methods to check a full picture of clinical reasoning in further studies, like in large scale studies if they are going to be conducted further. So the conclusion is that this was the first study using the Swift Concordance test in psychiatry. But this study shows that this procedure is very much feasible, like it can be conducted smoothly, and it can basically be conducted also in the low resourced countries, like which can't afford so much simulations and to conduct the high cost assessment methods. So, and its utility in the field of psychiatry for evaluating the medical students and their clinical reasoning competence. And it can provide a valid alternative to classical evaluation methods. And the recommendations I've already discussed. So thank you for your attention. And now, any questions?
Thank you so much, Dr. Sadia. We have a question from Dr. Rania. She is asking about what is the minimum number of vignettes could be used in the ST to be valid and reliable.
I think 30 to 35.
Remember that each item, Dr. Rania, from the SCT is one vignette with 3 items. So we usually multiply with 3. So according to my readings, the minimum is 20 item with 3 underneath points. So it means 60 for the minimum validity and reliability. But also it depends on this is a low stake or high stake exam. But I had one comment about that they mentioned that 10 expert is one of the limitation. However, 10 expert in literature is acceptable. Even more, some literature mentions that having a larger panel sometimes is more confusion, causing more confusion than having a moderate one. So normally it's from 10 to 15, so I don't feel that they are from the literature. But they were very sensible to mention this as one of their limitations.
Yes, they have mentioned, authors have mentioned that they considered that this was a limitation, according to them.
Okay, thank you so much to Dr. Sadia. Any question to Dr. Sadia or any comments about the article? Please, you can share it in the chat or just raise your hand and contribute verbally.
Yes.
Okay, thank you so much, Dr. Hind. The floor is yours.
Okay, thank you very much, Dr. Sadia, for sharing this with us. And thank you all for being with us today. Many thanks for Professor Dr. Asma, Professor Dr. Anjali for coordinating this event with us. And again, I'd like to thank Dr. Hadir, Dr. Sadia for participating in this session. Hopefully it was fruitful for all of us regarding the discussion. Thank you all for being again. See you for the next session, inshallah, for our journal talk. Thank you.
Thank you, everyone.
Thank you very much. See you.
Thank you.
Thank you, Dr. Sadia.